The topic for today's tutorial is infertility. The learning objectives are as follows. By the end of the session, the learner should be able to have an idea of the requirements for both female and male fertility in humans, including both the hormonal and anatomical considerations, and relate the knowledge of these elements into how problems can occur at each level, resulting in infertility. We also want to define for ourselves the term infertility, also known as subfertility, and classify it based on the timing of its onset, as well as the various primary causes of infertility. We also want to understand how infertility is investigated using basic terminology. And to round up the tutorial, we'll explain in basic details what IVF entails. This tutorial is designed for medical students at Cave Hill campus of the University of West Indies, although it might find some wider use in other circles. So first, what is necessary for female fertility? But to start us off, we just have an overview here of female reproductive anatomy in the pelvis. We've got our uterus, our fallopian tubes, our ovaries, and obviously the entrance to the genital tract is the vagina here. Dialing in on the ovaries, we've got a histological picture here, and this to introduce the concept of follicles. So what an ovarian follicle is basically tiny fluid-filled sacs which contain the eggs of the lady, and it's widely accepted that, it's widely known knowledge that women or girls rather are born with all of the eggs they will ever have, which come into the ovary during the embryonic period, having come from the yolk sac. So if we look here at this histological diagram of the ovary, we can see that from the outside in, we've got follicles at different stages of development. So the majority of these follicles with the eggs contained in them are going to be held in this stage here, which we call the primordial follicles, here on the outside, just beneath the tunic or the cloak, the tunica albuginea. So this outer area here with the primordial follicles, and the primordial follicles can sit there, pretty much from conception straight up until such time as menstrual cycles begin. And with puberty, you start to have the influence from the hormones from the hypothalamus pituitary axis, which we'll get into, which cause follicles to be recruited. So we get primordial follicles recruited with every cycle, and then you can have some follicles here growing. Eventually they become fluid filled and can be visible on ultrasound, and these we call antral follicles. So once they have this fluid filled sac called the antrum, these are the antral follicles. And like I said, the fluid allows them to be seen on ultrasounds as little black circles or dots. And at any given point in time, the number of antral follicles should roughly correlate in terms of the numbers seen to the ovarian reserve, or number of remaining eggs and follicles for development in the ovary. So with menstrual cycle in a human, we expect that one follicle becomes dominant. That's this one. So we call this a dominant follicle or graphian. This will grow beyond the size of 10 millimeters, probably to about 18, maybe up to 22, 24 millimeters before it starts to look to ovulate. Right? So ovulation is the process whereby egg is released from the ovary to be fertilized. Okay, so we've got this dominant follicle here, probably about 24 millimeters before it's ready to ovulate. So this is a necessity for natural fertility. An ovary with an ovarian reserve or follicular reserve. starting with primordial follicles, having growing follicles, recruiting antral follicles in each cycle. Antral follicles, which we can see count in part of our ovarian reserve, and eventually a dominant follicle with the rest of the primordial follicles becoming atretic. Sorry, the antral follicles becoming atretic, degenerating. Right, so we have some follicles here degenerating. So mentioning antral follicles, I have to mention transvaginal ultrasound, which is the primary way in which we would be able to view the antral follicles and certainly the dominant follicles as part of fertility assessment. And just to recap from a previous lecture, the transvaginal ultrasound is brilliant for assessing pelvic organs because it's so close to the action. It has high resolution. It's excellent for visualizing the uterus, which we showed earlier, as well as the ovaries with the antral follicles and maybe dominant follicles. Fallopian tubes are not usually visible on an ultrasound because they're so tiny, they're not filled with anything. So if you do see fallopian tube-like structures on the ultrasound, it has to be because there's something within the cavity, for example, an ectopic pregnancy or fluid like a hydrosalpinx usually. Right, so transvaginal ultrasound, excellent for visualizing the uterus and the ovaries in fertility assessment, and this is just demonstrating what, for example, a polycystic ovary will look like with almond-shaped ovary. Antral follicles are these, the ones which are between 2 and 9 millimeters, all dispersed throughout the ovary here, and this ovary happens to have more than 12 antral follicles, which is one of the Rotterdam criteria for polycystic ovary. So yes, we need to have an intact uterus, we need to have ovary with follicular reserve, and we need to have, to drive it all, this, which is the hypothalamo-pituitary ovarian axis. So the hypothalamus at the base of the brain, connected by a stalk to the pituitary. For our viewpoint as reproductive specialists, we are concerned mainly with the hypothalamic release of this gonadotropin releasing hormone, or GnRH, gonadotropin releasing hormone. So what the gonadotropin releasing hormone does is stimulates the pituitary to release gonadotropins. It is a releasing hormone for gonadotropins after all. And the two gonadotropins that we are concerned about here are luteinizing hormone, also known as LH, and follicle stimulating hormone, FSH. So we have two gonadotropins which will stimulate two sets of cells in the ovary. So usually the LH we associate with stimulating theca cells in the ovary that produces androgens. The FSH will stimulate the granulosa cells of the follicle, right? That would stimulate the follicular recruitment we spoke about with growth and selection of the dominant follicle to ovulation, which the ovulation is driven as well by LH. So FSH, granulosa, and follicles, of course, will produce in response to that FSH estrogen. The LH, the theca cells, will produce androgens, and the androgens are the substrate which is aromatized to create those estrogens in the granulosa. All right, so two cells, two gonadotropins. Now we can't be complete in our discussion unless we mention as well that the hypothalamo-pituitary axis seen on the previous slide results in changes in the hormone levels of the lady's body, which results in changes which we can outwardly see, both on ultrasound and in terms of menstrual loss in the endometrium. Okay, so we can marry these three concepts here. So at the beginning of the menstrual cycle, say cycle day 1, when the lady has started her menstruation, we always start the first day of the last normal menstrual period as day 1 of the cycle. So at this stage, we're just starting to recruit these antral follicles that we mentioned, the ones with liver fluid filled sacs. So therefore, those are recruited by this hormone FSH, which in a lady with several antral follicles, a nice premenstrual patient, should be at a level in this basal section, day 1 to 5, somewhere less than 8.9 as our value. Probably more than 1, but less than 8.9 should be pretty basal. So that if we'd have fewer antral follicles, we might expect that this FSH level will be higher, such as in a menopausal woman or a premature ovarian failure. Right? So we do have FSH recruiting those follicles during menstruation at the beginning of the cycle. Right? Because the follicles are at this small, low antral stage, we expect estradiol levels to be relatively low as well. And we were checking our basal hormones, we would expect that if we do FSH and LH, they would be relatively low, both below 10 in a premenopausal woman. With the shoot up, as I said, after menopause or before age of 40, we call that premature ovarian failure. Right, so that is basal, first 5 days of the cycle, and we can take advantage of this, as I said, by checking FSH, LH, estradiol. If we are concerned about menopause, estradiol would be absolutely low in the first 5 days of the cycle, right? Obviously, with menopause, you wouldn't be seeing cycles, but someone that maybe is premature ovarian failure and having fewer cycles, or someone approaching the menopause, you can measure these hormones at that stage, day 1 to 5. Okay, so follicles grow. Eventually, FSH declines because as the follicles are growing, estradiol is increasing, right? So this increase in estradiol is going to suppress the FSH. Remember, FSH causes estrogen secretion. So by feedback mechanism, you're going to need less FSH. All right. So eventually, the one follicle which has the most FSH receptors and thus can continue to grow with lower declining levels of FSH will predominate. That is our dominant follicle here. And that one continues to produce the estrogen, which results in the continuing climb. Remember, the effect of increasing estrogen is going to be to cause gradual thickening of the endometrium. So here during the menstruation, the estrogen levels are starting to climb. That should eventually bring the menstrual period to a stop. And as it continues to climb under the influence of the dominant follicle, we get thickening of the endometrium in the proliferative phase of the cycle. Right, so rises in estrogen, declines in FSH, thickening of the endometrium under the influence of this dominant follicle. So if we look at an ultrasound during this proliferative phase, we would see that trilaminar appearance where there's two clear areas on either side and a bright line where the two sides of the endometrium meet in the center. That is a proliferative endometrium. Now, once the estrogen levels reach this critical juncture where they're reached pretty much a peak here, rather than having that same negative feedback effect which was keeping the FSH suppressed, it paradoxically or strangely would result in a surge in the other gonadotropin, which is LH. So you see that LH here was relatively low, kind of suppressed by the lower levels of estrogen, as was the FSH. But paradoxically, when you get this high level of estrogen, there's a LH surge. So the LH shoots up, and that luteinizing hormone surge causes luteinization of this follicle and causes release of the oocyte or egg. We call that ovulation. All right. So the LH surge luteinizes the follicle. It causes ovulation, and luteinizing the remaining part of this follicle results in the formation of this corpus luteum. So the luteinizing hormone luteinizes the follicle, results in the corpus luteum. All right, but important to know this LH surge results in ovulation, and we can detect this. Right, it tends to precede the ovulation by about 24 to 36 hours or so. So if the lady is checking her urinary LH, maybe using a persona or using ovulation predictor kits, which are kind of urine test kits with a double line, just like a pregnancy test, then she can detect this surge and know that she's likely to ovulate the next day. So that can be used to time intercourse, for example, because ovulation is the most fertile time of the cycle. We can use also to time inseminations, artificial inseminations, showing that LH surge occurs. All right, so detected on a blood test or a urinary test kit. All right, so LH surge, ovulation, what happens to the endometrium? Well, basically, the corpus luteum being formed is going to result in this. This is the progesterone line. So the corpus luteum secretes progesterone. So we know that once she has ovulated, the progesterone level is going to climb. If she hasn't ovulated because of whatever reason, the progesterone level is going to remain low. Okay, so once we get a rise in progesterone here in this luteal phase, it comes to a peak, we know she's ovulated. So that progesterone has an effect on this endometrium. It's going to cause it to be matured, become secretory, we call it. So we get blood vessels becoming kind of twisted, tortuous, they call that, kind of turn and coil on each other, on itself. Secretory, so it's going to have increased gland secretion and so on. It's not going to have that nice tree stripe look like on the ultrasound in the proliferative phase. It's going to have a more homogeneous, bright echogenic kind of look in the secretory phase. So once we see that secretory change, it's likely she has ovulated. If we can get a progesterone level in the middle of the luteal phase, in the mid-luteal phase, a mid-luteal progesterone level, which is something above, say, more 30 nanomoles per liter, we can say that this lady has ovulated. All right. So should she become pregnant, the corpus luteum, of course, will continue to secrete as a corpus luteum pregnancy, the progesterone, and that will keep her pregnant. However, if she's not pregnant, the corpus luteum regresses, becomes what we call the corpus albicans, and of course, as it regresses, it can't secrete as much progesterone. That progesterone is going to fall back again. And this withdrawal of progesterone, that fall is called a withdrawal, is going to cause a withdrawal bleed. So it stops the secretory effect. And once the progesterone has fallen to critical level, the endometrium is shed. And that's menstruation, starting the cycle back at day 1 again. Okay, so this is an important diagram, and it shows us how we can look at the hormones, look at the endometrium, look at the follicular development and stuff, and determine the patient's fertility and where she is in her cycle. So day 1 to 5, basal hormone, FSH, LH, estradiol will allow us to know if she is normal gonadotropic, normal gonadism, if maybe she's hypergonadotropic, hypogonadism, like in the menopause, or hypogonadotropic hypogonadism, if there's pituitary or hypothalamic failure. So we do that basally. We can manipulate, as I said, the LH in order to detect ovulation in ovulation predictor kits. Right. This rise in estrogen here causes spin barket, which is basically the mucus of the cervix becoming thinned out and stretchy, and that way sperm can pass through. So if she sees this change in her mucus that is thin and stretchy at peak estrogen, she knows that she's probably going to ovulate soon. So that can be used. And of course, this progesterone climb afterwards causes that mucus to become thick and inhospitable to sperm, viscid. So that is the infertile mucus that you get after there. All right. Don't forget too that this progesterone climb causes a change in basal body temperature. So once she has had her peak change in her basal body temperature, she has probably ovulated already. So that's kind of a more retrospective confirmatory thing. Probably not best to use time intercourse because ovulation already have occurred, but that climbing progesterone causes a change in basal body temperature. And yes, we can look at the endometrium to try to determine on ultrasound which stage of her cycle she's likely in. Look for that dominant follicle, for example. We can use antral follicle counts to determine her ovarian reserve along with the FSH, LH, and so on. So this is very useful for us as fertility managers and very well learned. Here it is again, with a bit more numbers to it. So here on the y-axis, we're showing a few of the numbers that I would have mentioned. So basically, our during menstruation, our FSH and LH should be less than 10 international units, certainly less than 8.9 for the FSH if we use nice guidance. If we take basal hormones and estradiol in picomoles, should be relatively low as well. And here we see that LH surge, we can get LH is suiting up here in the regions of 80 international units per liter. And then here we can see our mid-luteal progesterone peak. So in a 28-day cycle, we expect ovulation to occur around day 14, as the luteal phase tends to be consistent at 14 days. So we expect that midway in there, so between 28, 14, the midway point would be day 21. So a 28-day cycle should get a day 21 as the mid-luteal progesterone, or day 21 progesterone, which should peak above 30 nanomoles per liter to confirm ovulation. We would, of course, adjust that day of testing based on the length of the cycle. So, for example, a 26-day cycle, the mid-luteal phase should be around day 19. A 30-day cycle, 30 minus 14 would be 23. Sorry, 30 minus 7 would be day 23 progesterone, would be the mid-luteal peak. So average woman, average 28 days. Most often we will end up doing a day 21 progesterone for confirmation. If she hasn't ovulated or maybe ovulates late, in some occasions you might repeat the progesterone a few days or maybe as much as a week later just to catch that peak. So just suffice to say that mid-luteal progesterone might be impossible to get in a lady with irregular cycle. So you might dispense with that, but if you have somebody with a regular cycle, you should be able to confirm ovulation with mid-luteal progesterone above 30. Just illustrating again the concept of raised levels of estrogen just before ovulation, just before the LH surge. That raised level of estrogen causes this stretchy mucus. That's thin and easy for sperm to penetrate. So stretchy, can look like egg yolk between your fingers. That's called spin barkette. If after ovulation, the progesterone causes it to thicken up and become impassable to sperm again. Progesterone causes the mucus to be thick and impassable, and that's post-ovulatory or also pre-ovulatory, non-ovulatory mucus. So aside from follicles, growing follicles, dominant follicles, ovulation in response to the axis, we obviously would need to have fallopian tubes, which are working, which are open, patent. All right. So the fallopian tubes, of course, will have a fimbrial end. So this demonstrates here a dominant follicle under the influence of the LH surge causing ovulation, release of the egg. And the egg is taken up by these fimbria, the words kind of like fingers. They kind of look like finger-like, don't they? Into the ampulla, right? So here, the sperm would have come the opposite direction, waiting to meet the egg here in the wide part of the tube. Is called the ampulla. So this demonstrates here that we do need an intact fallopian tube from end to end, fimbrial end, ampulla, through the isthmus and the infundibulum, and then also intact endometrial cavity for implantation, open cervix, open vagina. So we need this entire passageway end to end to be open in order for sperm and egg to meet, for fertilization to occur. So we also need active sperm which can swim to meet the egg, which can meet with the egg. Here, this is showing the binding of the sperm with the oocyte, penetrating the zona pellucida. It needs this acrosomal tip, which acrosome contains the enzymes which digest through the cumulus and the zona in order to allow the sperm to penetrate. So here it's going to lose its tail, and the nuclear material from the sperm is going to go into the egg to cause fertilization. So we need a receptive sperm and egg combination, probably a normal functioning sperm, motile sperm, and receptive eggs which have been ovulated in order for they to become pregnant, and they should meet in the fallopian tubes. Here we have the vision of the new organism into 2 cells, 4 cells, compacting here 8-cell morula, eventually becoming a blastocyst, which will hatch, meaning kind of pop out, ready to implant here into this endometrium. So we do need a receptive endometrium as well, and the embryo to develop to the blastocyst stage, hatch, and be implanted. So thus and therefore we can see that disruption at any of those stages in the female hypothalamal axis, pituitary axis, ovarian. So disruption at hypothalamus, pituitary, ovary, failure of the development of follicles or absence of follicles, failure to ovulate, or failure of the genital tract to be open, as in patent and receptive, or reasons for infertility as a flip side to what we've shown for fertility. So next we talk about what is necessary for the male for fertility, as in for conception to occur. So here we have a diagram illustrating the male genital tract. So again, another sequence of pipes. We start here with the testis, which again is stimulated by that hypothalamo pituitary gonadal axis. And here the gonad is going to be the testicle. So similarly in the female, if there's disruption at the hypothalamic level, pituitary level, or testis level, no sperm can be produced. Next we have our epididymis, which is where the sperm are emitted in order that they can traverse this vas deferens or ductus deferens. Alright, so we need all this here to again be open, patent, and working in order for the sperm to be transported through the ductus all around this way here. Right, some fluid is going to be added by the seminal gland as well as the prostate in order to give the semen its appearance, its volume, its pH, right? Its normal pH. And then you're going to have ejaculate coming through the urethra and out through the urethral opening here. So we need all these pipes to work, but also we will need them to be able to copulate. So the man would need to have erections occurring readily, as well as intact nervous system to result in ejaculation, erection and ejaculation, right? Which obviously should be in a forward direction. So nerve damage and so on could obviously result in backward or retrograde ejaculation, where sperm can end up in the bladder, and that's not conducive to fertility. Also failure to obtain or maintain erection, or blockages due to traumatic damage, infections, etc. Maybe even electively disrupting the vas deferens, such as a vasectomy, where you have part of the vas cut, ligated, maybe separated by some tissue. All can cause a loss of male fertility. So of course we're talking about sperm being produced. So similarly to the female, we do have sperm progenitus, spermatogonia. I like to remember this as goal, site, primary and secondary, I, fertility, goal site and IV, basically. So spermatogonia would result in primary spermatocytes, secondary spermatocytes, that's goal site. IV would be I spermatid, and then of course the final mature stage is going to be the spermatozoon, right? So what we call sperm for short is really the spermatozoon that's ejaculated. It has an acrosome, like we said, for penetration. Head, the nucleus contains the genetic material to fertilize the egg. The neck, the mid piece here are going to be important, particularly in the mid piece for energy, because it has in the mitochondria energy for the sperm to move. So if we have absence acrosome, sperm can't penetrate. If we have a mid piece defect, sperm might not be as motile because the mitochondria or the energy is missing. We also have the tail. So a tail defect obviously can result in uh, poor motility as well. So good. Now that we know what's needed for fertility, we can talk about infertility. So infertility is defined by the WHO IC marked glossary as a disease of the reproductive system defined by the failure to achieve a clinical pregnancy after 12 months or more of unprotected sexual intercourse. So this implies that a man and a woman are having heterosexual intercourse with ejaculation into the vagina, as we've shown. Regular intercourse usually means every 2 to 3 days or 2 to 3 times per week. Should within a 12-month period usually conceive, and beyond that, statistically, they are delayed, and thus we would define them as being infertile. So this supposes that everything else between them is optimal, such as the lady's age being less than 35. Should we have a lady above 35, then it becomes a bit more urgent. We might start evaluation after, say, 6 months. But this is the standard definition here. How common is it? About 1 in 7 couples in developed countries would usually have infertility. So it's pretty common, and it's estimated to be slightly lower in developing countries. So we can classify infertility in a number of ways. One is based on the timing, whereby if it's primary infertility, we mean that man hasn't conceived before. If it's primary for the male, primary for the man, woman hasn't conceived before. If it's primary for the woman and she's presenting, but most often we talk about for the couple. So primary for this couple if they haven't conceived together before. We can have secondary infertility. So if they've had a conception either with their partner together, which is couple infertility, or either on their own, they can have secondary infertility. So they've conceived in the past, but now they're having problems conceiving. Maybe met that 12-month criteria. They're now secondary subfertility. But we can also classify subfertility based on factors, or what we call factors. So we have a broad category of male factor, and here illustrates maybe some sperm abnormalities, which we mentioned before that sperm should have a particular kind of structure in terms of head, mid-piece, tail, which is normal and kind of strict in the WHO manuals. We tend to use the WHO 2010 as to what normal looks like, and variations in head shape and so on might imply DNA damage, etc., and sperm that are not as readily able to fertilize eggs. And of course, mid-piece and tail can cause problems with motility and thus the sperm reaching the egg. Male factor infertility tends to be classified as pretesticular, meaning the hypothalamus axis that we talk about, hypothalamus pituitary testicular axis. Testicular, meaning there's testicular failure. Or post-testicular, meaning there's a blockage, so obstructive male factor. So we usually would assess the male element of the fertility using a standard test, a semen analysis. And the semen analysis is done after a period of abstinence, maybe about 3 to 7 days, on average 5 days of abstinence. Usually the gentleman would produce the sample manually directly into a specimen container, a sterile container, without the use of lubricants, because remember, lubricants can contain spermicides, and without using condoms, again, which can contain spermicides, or withdrawal method. So directly manually into a container, and the specimen should be ready within an hour at body temperature. So it should be handed in right into the lab, or if transported, maybe kept close to the body under armpit or on the belt or something. And the reason for that is so that it maintains its integrity, particularly its motility. If you keep the sperm too hot or too cold, the sperm won't swim as well, and you will get an incorrect value, right? So once we have the ejaculate, microscopically things can be evaluated, as well as the pH. The volume should be more than 1.5 milliliters. All these lower reference values tend to be the 5th centile for the population. So below this 5th centile, we expect that the sperm parameters are low. There might be a delay in male fertility, even though male fertility is kind of difficult to quantify because the number of sperm and the motility might not translate into whether a baby can come or not. But these are the lower limit for the values, the 5th centile, and below this concentration, for example, less than 15 mil is low. All right, so you look for pre-testicular, like a hypothalamo-pituitary axis cause or testicular cause here. Blockage might result in azoospermia, which is 0 sperm, for example. Volume, again, we said contribution from the prostate and contribution from ejaculatory ducts and so on. So if the volume is low, we have to look at the health of his genital tract and his prostate, etc. That's pH, definitely contribution from the prostate. The concentration should be 15 million in each of these milliliters. All right, at least. So fewer than that, we call that oligospermia. So, right. The motility, there's two types of motility. We have progressive, meaning forward. So if I'm going straight towards the target, that is progressive. If maybe I'm going from side to side or rocking, twitching, that's non-progressive motility. So we're keenly concerned with the progressive motility in particular, although we do look at total motility because that tends to speak to the next thing, which is sperm vitality, sperm that are life. So total motility should be at least 40% to say this is a good sample. At least the progressive motility should be at least 32%. The number of normal forms using those strict criteria we talked about with WHO 2010, looking at those strictly normal forms, should be at least 4% to meet WHO criteria. So I would say the key ones to remember are we want a volume at least 1.5 mil, a pH of at least 7.2 to say it's alkaline enough, again, prostate health and so on, concentration of at least 15 million per mil, progressive motility, the important one, 32%, and 4% normal forms. 15, 32, 4. Important to know. So should we have something which is less than these, so oligospermia, less than the normal concentration, asthenozoospermia, which is less than the normal progressive motility, teratozoospermia, terato like monster, less than the normal forms, or combination like oligoasthenoteratozoospermia, then we might suppose that there are environmental changes, health changes, and so on that might result in an abnormal sample. So with the knowledge that it takes about 3 months for a sperm to go from a spermatogonium straight through the cycle of production of a new spermatozoon, the normal sample should prompt a second one 3 months later. If it's profoundly abnormal, like azoospermia, for example, you could repeat it again right away, right? Again, to allay anxiety and to maybe expedite the process of finding a reason. So that's male factor. So the next huge category is going to be female factors. And I think we can classify the main ones there into ovulation disorders, so problems of release of the egg. So remember, we need release of egg, then we need to have patent fallopian tubes. So the next thing is tubal factor is a big one. We might have some peritoneal factor, so things like endometriosis and so on can cause infertility, and then some miscellaneous ones, so maybe endometrial factors, maybe cervical factors, etc. Those tend to be the more small categories. So the big ones are going to be ovulation problems and tubal factor. And of course, we have to talk about what's meant by unexplained infertility. So when it comes to ovulation problems, failure to release an egg, we did mention we need a hypothalamus pituitary gonadal axis. We can classify the type of disorder that we find when we do our basal blood FSH, LH, gonadotropins, and estradiol into 3 groups under WHO. So these are the WHO categories of ovulation disorder. There's group 1, group 2, and group 3. So group 1 is going to be where the axis has failed at the hypothalamus or pituitary level. All right? And that is going to be your hypogonadotropic hypogonadism. So the LH and FSH are low, which means that because there's not enough to stimulate the ovaries, the estrogen level is also going to be low. Hypogonadotropic, low LH, FSH, hypogonadism, low estradiol. So this is going to include your hypothalamic problems like your anorexics, maybe anorexic, bulimics, teenagers that overexercise and thus don't have that critical body weight, maybe some tumors like craniopharyngiomas, etc. of the hypothalamus, maybe hypothalamus or pituitary irradiation. Also, some pituitary tumors either compress the stalk or cause failure to release LH and FSH, and thus levels will also be low. All right. Don't forget Sheehan syndrome, which is basically pituitary necrosis. So pituitary becomes ischemic after maybe a postpartum hemorrhage that can cause a group 1 or a hypothalamic pituitary failure. So the way to get around that obviously would be to give them what they're missing, gonadotropins in group 1. Let's skip over to group 3 for a second, because this is going to be not hypo but hypergonadotropic. So this is a category that's ovarian failure, the ones that look like menopause. So you mentioned that their estrogen level is going to be low, but that's because the ovaries have failed. Not the hypothalamus or the pituitary, but the ovary has failed. And thus the hypothalamus, still working, and the pituitary are going to over-respond to try to compensate. So you get high levels of FSH and high levels of LH, hypergonadotropic. But still, because the ovaries are basically devoid of follicles, the ovarian reserve is gone, all the eggs are gone, we have low levels of estrogen still. So these ones are not going to respond to treatment. They would need to have, since they have no eggs, ovarian failure, IVF cycles with donated eggs from a younger woman. In between these is the most common group. So if you encounter somebody with ovulation problem, the most common thing they can have is a group 2 disorder. So they call this hypothalamic pituitary dysfunction or normal gonadotropic normal gonadism, because the LH and FSH and the estradiol are most often going to be normal. These are predominantly going to be polycystic ovary syndrome. If you have something different in the LH and FSH, it might be a raised level of LH, luteinizing hormone, which sometimes can be higher in PCOS. That's ovulation problems, and this is just a brief one short reminder of some of the features that help to diagnose PCOS. All right, because of the ovulation problems and they're not ovulating regularly, like we saw in our previous slide with the axis and the menstrual cycle, the irregularity of the absence of ovulation means that their period is not going to come on time. It's going to come all over the place. So they can have very frequent periods or months and months and months without periods, and it's because they're not ovulating. Should we restore ovulation in them? Should we restore ovulation through weight loss or other interventions, ovulation induction interventions, then their cycle will certainly become regular again because of ovulation. So the next big category is tubal factors. So here on this side we have what looks like the tube we saw before, a normal tube. But should we have things like scarring adhesions, right? For example, from past infections, like a pelvic inflammatory disease infects the fallopian tube, you can get adhesions inside, you can get adhesions outside, or previous surgery like an appendix rupture or a laparotomy, they can get adhesions which can distort, twist, block or otherwise block the fallopian tubes and result in tubal factor. So if you asked about causes of tubal factor, think things that cause adhesions on the fallopian tubes, endometriosis, and so on. And here is an example of a blocked tube. We have this person has salpingitis isthmica nodosa. So tube blocked at the femoral end, continue to secrete in its normal secretions, as most hollow organs in the body will secrete something. It's continue to secrete, you get the tube ballooning out like this, and that produces the hydrosalpinx, and that's one of the only times you would see a fallopian tube on an ultrasound. So this person also has some adhesions here which could be contributing. Maybe they've had a past pelvic inflammatory disease or something. Endometriosis can cause tubal factor infertility in severe forms like this, where the anatomy is distorted and you have tubal blockage and so on. But we do know that even mild forms of endometriosis somehow can cause infertility, and there are various theories around that, mostly having to do with the inflammatory environment perhaps causing phagocytosis of sperm or destruction of embryos, failure to implant, and so on. So people even with mild endometriosis are more likely to present with a delay in fertility, but with otherwise normal semen analysis parameters, patent fallopian tubes, and ovulation demonstrated, their prognosis overall remains fairly good. But severe cases like this is maybe a stage 4. So the stage 3 and stage 4, the moderate to severe endometriosis can have blockage, anatomical distortion, and they can also have large endometriomas, which are basically what we call chocolate cysts, big cysts which destroy ovarian tissue, compress it, and maybe make it difficult to attain eggs at IVF cycles. Those can cause infertility for obvious reasons. Just to mention too that there are associations with obesity and infertility for various reasons. It's thought that there's a delay in women with BMIs above 30 due to changes in the hypothalamic axis. We know body fat does produce estrogen, so that can mess with the cycle and thus result in anovulation, irregular periods, which go together, impaired development of follicles because of suppression of the FSH. There might be an effect on endometrium, not allowing the embryos to implant. The embryos might develop more poorly as well. So we know that women with higher BMIs above 30 are more likely to need fertility treatment, and because of the BMI they may also need higher levels of medication in order to make their body respond to treatment such as ovulation induction and IVF. Men are not immune from the effects of BMI either. Men with a BMI above 30 can have, again, impact on their hypothalamic axis because of production of that estrogen, causing reduction in sperm. So oligospermia, low levels of sperm, azoospermia, no sperm, more common in the bigger men. It might result from that hormone influence, but also from if the belly hangs and heats the testicles, because testicles tend to be kept cool in their scrotum, and with loose underwear and so on, we expect that sperm production is better. And if you have a tummy that's hanging and making the genitals hot, that can reduce the sperm. So there's also suspicion that there might be some sort of sperm DNA damage, etc. They tend to have reduced pregnancy rates in their partners based on the published evidence. So that all said is impetus for us to encourage both both female and male partners to try to obtain a body mass index in the normal range. So if we have gone through our evaluation of ovulation, ovarian reserve, fallopian tubes, semen analysis, and all those things that we can test for are normal, we have this residual category called unexplained infertility, which I suppose is the most frustrating category as a residual, but all told, very often has a good prognosis. So up to 2 years, the prognosis seems to be good, that they can have good chance of becoming pregnant after the 2-year mark. Then IVF is usually recommended, although in centers where that is not feasible, things such as intrauterine insemination can be tried. So next we talked about some general infertility management principles. So it makes sense that if it takes both a man producing sperm and a woman with her eggs, and they happen to come together to meet, and they need to obviously have a relationship and perform what's necessary to become pregnant, we should evaluate them together and do all the tests in tandem. Both partners are influenced by the decisions which need to be made, so everybody needs to be on board. So good to see that, that sort of support as well. Women seem to like it as well, better attending for evaluation with their partner. And they're both affected obviously by treatment. We both need to be investigated. We have here. We should, wherever possible, provide both verbal and written information, so information leaflets, things that they can read and digest, because as you can probably gauge from now, there is a lot of information about fertility and getting pregnant and how you can help. It might not be just in one session, so where possible, written information should be supplied. And it's useful to address stress that might sometimes need counseling from a psychologist or something, because stress raises level of prolactin, can stop ovulation, it causes and raises cortisol. It might reduce libido, cause problems with ejaculation and erections, and reduce the frequency of intercourse. So it's important to address stress. Here we've demonstrated the template we use for history taking in the fertility clinic at our hospital. So we tend to put the lady's age up here. Age is important again because the older the lady, the more difficult it is to become pregnant, and we know that beyond 36 things become a bit more urgent because of fall in the ovarian reserve. Also, we tend to put whether the fertility is primary or secondary for man, woman, and couple respectively, how long they've been together, how long they've been trying. Cycles. We look at the time of menarche, which is on average 11 to 12 in our population. A late menarche might be suggestive of a hypothalamic problem, such as the anorexics and adolescents we talked about, the athletes we talked about. We look for amenorrhea, which can indicate, or irregular periods as well, which can indicate ovulation problems. Regular cycles indicate regular ovulation. Yes, irregular cycles, they're not ovulating. Believe you me, irregular cycles, they're not ovulating. We asked about irregular bleeding, abnormal bleeding, intermenstrual bleeding, postcoital bleeding, because things like polyps causing intermenstrual bleeding, endometrial polyps, postcoital bleeding, cervical lesions, and trichomonas can also cause postcoital bleeding. The last menstrual period allows us to kind of rationalize what we see on the ultrasound, determine if the woman could already be pregnant. If the pregnancy test is negative and she's had a period of amenorrhea of 3 to 4 months in a PCOS patient, that might be an indication to induce a withdrawal bleed with progesterone tablets. Contraceptive history, kind of want to know what she's used, if she's doing any contraception recently. Remember, they do have sometimes delay in return of conception after, for example, Depo-Provera, up to 9 months a year. All right, maybe she has been on the pill, or maybe some progesterone for heavy menstrual bleeding. I didn't realize it was contraceptive. So we need to basically ask questions around these things in order to move forward. Pregnancy history, we want to know her priority. Basically, we want to know how she conceived each time, whether it was spontaneous, if she needed maybe some treatments, IVF, how she delivered. Vaginal deliveries, relatively innocuous. Cesarean sections may have adhesions, both intrauterine, the Asherman syndrome, extrauterine tubal abortions, whether miscarriages or induced. Recurrent miscarriages can have implications for how we treat because she might have antiphospholipid syndrome. So early pregnancies might require extra treatment if you evaluate and find that. But terminations, ectopics, can cause damage to the genital tract. So, for example, suction termination with an infection, so abortion complication, can result in Asherman syndrome, especially if she's had a DNC, right? Ectopic pregnancies obviously can be disruptive fallopian tubes, so we shouldn't know if this is managed medically or surgically. And remember, ectopics can be in the setting of tubal damage underlying already endometriosis, pelvic inflammatory disease. Molar pregnancies can reoccur. Intrapartum complications, remember again, Sheehan syndrome, pituitary necrosis can result, again, DNCs, Asherman syndrome. So good to have obstetric history in order to make sure you've got a good idea of things that might have happened with previous pregnancies, which can have shed some light on what's going on at the current time. So past medical history, we asked about major medical illnesses, diabetes, thyroid problems. Diabetes obviously has implications for conception in that if she has a high hemoglobin A1C, she has a high risk of fetal abnormalities and miscarriage. So we want to know that if she has it or not, and we want to aim for A1C less than 6.1 if possible. Thyroid problems, hypothyroid in particular, needs treating because it causes anovulation and also has implications for miscarriage and so on. Chemotherapy, radiotherapy, chemotherapeutic drugs can cause destruction of egg supply. Thromboembolic disease goes along with recurrent miscarriages and antiphospholipid syndrome. So you also want to know if she's had surgery on the fallopian tubes, removal of ovaries, fallopian tubes, maybe appendectomy with adhesions. If she's had laparoscopic myomectomy, which can have adhesions as well, and fibroids do recur. Cervical problems, we usually check those because last thing we want is somebody to become pregnant, hadn't had a pap smear for a while, and then has cancer of the cervix. Or last thing we want is to end up with fertility treatment where we want to traverse the cervix and we can't because we didn't know she had ablative or destructive procedures of the cervix. So we need to make sure her pap smear is up to date. If she hasn't had one, do one and make sure everything is normal before proceeding too deep in our fertility treatments. Here we've got a section on current vaginal discharge, past STDs. These have implications for tubal blockage as mentioned. A lot of hormonal type questions here. We always think about prolactin. Hyperprolactinemia causes ovulation problems, so breast problems and nipple discharge. Polycystic ovary, ovulation problems, goes along with acne, hirsutism, hair loss in the temporal region. Menopausal symptoms, hot flashes, night sweat, mood swings, what we call the vasomotor symptoms, go along with the class 3 disorders, hypergonadotropic hypogonadism. Weight loss, again, ovulation problems, the class 1. Weight gain goes along with your PCOS, or either one can go along with thyroid problems, as does neck swelling and heat or cold intolerance. Always ask about folic acid because folic acid is a supplement required for fetal development, particularly of nerves, reduction of the risk of neurotube defects. So every woman should be on folic acid when trying to conceive, and up to 12 weeks of pregnancy. 400 micrograms is the standard dose for usual women, but if they have a BMI above 30 or antiepileptics, sickle cell disease, diabetics, those are categories that would need a higher dose, 5 milligram. Also, let's check the drugs because all drugs are not safe to conceive on or get pregnant on. For example, the diabetes we mentioned, we would want to get off of most hypoglycemics and maybe switch to metformin and insulin, which are safe. So do a good drug history. Remember, certain drugs can also cause ovulation problems, raisins in prolactin, etc. Allergies, obviously we want to know if we are treating a patient about her drug allergies, that goes along with it. The occupation we do need to know because implications for timing of intercourse, stress, uh, maybe exposure to chemicals and pesticides in the work. Diet and exercise we also want to know about because over exercising might be bad for your hypothalamic health. For example, or PCOS people not exercising might have high levels of insulin and not be ovulating. Smoking, alcohol consumption, recreational drug use, all detrimental to growing fetuses, so we encourage them to stop. Also, smoking is detrimental to ovaries and their egg supply. Smoking ages the ovaries and causes reduction of ovarian reserve way ahead of timing. HIV has implications for how you treat and how you handle gametes and timing of intercourse. So the more frequently they're having unprotected intercourse with HIV, the more likely they are for the non-discordant couple for the HIV negative partner to contract. So good to know upfront if they've got HIV. Family history of cancer. Remember, some cancers are associated with problems in the ovary, etc. Good to know history of diabetes because this patient will be risk of diabetes, maybe PCOS also rests in the family, metabolic disease. That boils back down to the antiphospholipid. So we have some similar questions for the man as well. Of course, we also want to know if he has had any fertility in the past and how long ago, because things happen. He might have had an 11-year-old kid, but then had some urethral stricture from a chlamydial infection or so on. So kind of want to know, yes, if they've been conceived together, this union, if he's conceived in the past, how long ago, how old was the kid, what happened to that pregnancy, recurrent miscarriage, for example. We want to know if he's had a semen analysis before, the details of that. He might have had with a previous partner or this partner, and everything might be laid out in terms of a cause of infertility just from that. Chemotherapy, radiotherapy can cause oligospermia by a testicular problem. Diabetes, erectile dysfunction, thyroid problems, similarly can cause hypothalamic pituitary disruption, like in the female, and thus oligospermia. Vasectomy and vasectomy reversal kind of self-explanatory. Blockage of sperm passage or reversal might or might not have worked, but he's more likely to have antibodies against sperm with a reversal and might need to have advanced treatments. Hernias, hypospadias, and all these other things down here, orchidopexy, orchidectomy, testicular surgery, torsion, varicocele injury, tend to be more implicated with damaged vascularity, and direct damage to the testicle can result in oligospermia or such like. Make the semen analysis a bit more, of course, pertinent, although we do need a semen analysis for everyone. MESA, TISA, basically microepididymal sperm aspiration, testicular epididymal sperm aspiration. Those are ways to retrieve sperm after maybe a vasectomy or something in order to circumvent a blockage, and they're using IVF. If they've had that before, it's obviously good to know that. Medications, again, like the woman, things that can cause high levels of prolactin. Don't forget to ask about anabolic steroids for bodybuilding. Remember that if they have testosterone from an exogenous source, that can depress sperm production. Also, drug allergies. Recent fever. Remember, fever can change how your semen are produced. If you've had fever recently, you might, of course, want to repeat the semen analysis if you have abnormalities. Urinary infection, STDs, can cause blockage strictures in the genital tract. And moving on. Similar situation with job factors. Remember to ask if, for example, he's a truck driver. Hot engines on the seat can cause testicular temperature to rise, can cause problems with sperm production. Again, time away from home is a consideration. Exposure to chemicals, pesticides, same diet and exercise factors as for the lady. So for the man, smoking also can cause problems with the sperm and also the ejaculate in which the sperm have to swim. So you do encourage stopping of smoking of all kinds. That includes marijuana. Alcohol can also be detrimental to sperm. So it might be worthwhile having them stop the alcohol, the weed, and the smoking, and for a bit, before doing your semen analysis if that's the sorry, that's an issue. We talked about HIV a bit already. So once we've done the male's history, we can speak to them, the couple, at a point now where they might be comfortable speaking about their sexual history, about their sexual frequency. Because remember, we say optimal frequency for trying is about every 2 to 3 days. If you acknowledge that sperm in the genital tract, it's usually viable, maybe up to 5 days, right? Certainly comfortably up to 72 hours, sperm can swim in the genital tract and potentially make sperm. So if there's ejaculation every 2 to 3 days into the genital tract, she ovulates. Even if she's not expecting, they're more likely to conceive. And it also takes the pressure off of and stress off of trying to time intercourse based on tests and body temperature and that kind of thing. So every 2 to 3 days is optimal. Every day is maybe counterproductive because frequent ejaculation does result in reduced semen analysis volume as well as semen concentration. So every 2 to 3 days is the sweet spot. They like each other. The sperm is healthy, not too old and not too depleted from the too frequent intercourse. 2 to 3 days is what you tell them. You might check if they're time ovulation, using apps and predictor kits and so on. Usually would suggest that they are ovulating, even though you do try and encourage every 2 to 3 days intercourse anyway. Dyspareunia might reduce copulation and intercourse, particularly the deep dyspareunia, which obviously might cause the lady to not want to have as frequent intercourse. This is associated with things like endometriosis, which we know is a cause of infertility. Erection and ejaculation, I think we mentioned briefly, need to occur, so you need to be sure that they're adequate, and whether they have any sexual problems like maybe vaginismus, fear if it's been maybe the ladies had a traumatic experience in the past. It's always good to note that. So next we talk a bit about examination. So we have here first female partner. Height and weight should give us a body mass index. And we talked about the importance of body mass index. Extremes are detrimental: low BMI and ovulation, high BMI and ovulation. The lower one usually will have maybe hypothalamic and ovulation. The higher ones could have PCOS. Important to note the BMI and encourage optimization. General examination you should do, including hair distribution, which can be increased with a high ferromegalovirus score above 8 in PCOS. Breast development, which can be delayed with a lower tender stage in premature ovarian failure, so hypergonadotropic hypogonadism, or on the flip side, hypogonadotropic, right? So low levels of estrogen would delay breast development. Galactorrhea goes along with high levels of prolactin, which results in poor ovulation, breast lumps. You should always check for as well. Abdominal examination might detect scars from previous surgery. You might detect masses like big fibroids and so on, and you can plot your findings here on these side of diagrams. Doing a pelvic exam, it's not always essential, but it might give you good clues. For example, you might see a stenotic cervix. You might have genital blocks in some women that might have had primary amenorrhea. You can take swabs for infections. You'll check for chlamydia. You can do pelvic assessment for PID. All right, but very often you will, in fact, do a pelvic ultrasound, which will give you useful information about the structure of the uterus, as we saw, the appearance of the ovaries, which can give you an idea of the ovarian reserve from the antral follicle counts, whether high or low, etc., or normal. And that is usually part of the female assessment. For the man, similarly, BMI assessment, same reasons, and general exam usually, and a testicular exam will usually occur in those who have maybe oligospermia, looking for causes. So features of hypogonadism will go along with low testosterone from either a pretesticular cause or testicular cause. Gynecomastia will usually go along with high levels of estrogen or more so prolactin or certain medications. Abdominal exam You might detect again masses. You have a look at the hair distribution. A man should have hair on his abdomen. All right. Um, and he should probably, frequently shave and have hair over his body if he has normal testosterone and normal development. Hernia orifices. Sometimes if you find a hernia, that might be implicated again in oligospermia. Testicles, you might examine them and determine the size with relation to orchidomata. Smaller testicles, shrunken ones, can go along with testicular damage and testicular failure from orchidopexies in the past, etc. There should be two, testicles as well. Scars from orchidectomies or vasectomies. You should be able to feel and palpate the epididymis on both sides. Remember, if they have, if you've tried to palpate for the vas and you can't feel it, congenital bilateral absence of the vas difference, CBAVD. If both vas are missing, think cystic fibrosis carriers, CBAVD. Right? Look for varicoceles, can increase testicular temperature. Inguinal exam, check that the penis openings are normal as well, and that penis development is normal. Right. So in terms of advice, we mentioned sex every 2 to 3 days, minimize alcohol, minimize smoking cessation for these reasons. Alcohol develops sperm-developing fetuses, semen quality, sperm cessation. Smoking cessation because association with reduced female fertility and sperm quality. BMI reduction. Folic acid we mentioned as well. Standard dose 400 micrograms is found in most prenatal vitamins, and those that we mentioned with increased risk, NTDs, epileptics, diabetics, 5 milligrams per day when trying, and up to 12 weeks of pregnancy. That is our mantra. So very often these people would present to you as general practitioners. You do refer them after that 1 year of intercourse, but if of course the lady is above 36 or she has a known risk factor for infertility, like previous chlamydia, previous appendix, etc., ectopic, you can refer them for evaluation in fertility clinics. Here's just a diagram showing the fall in fecundity, fertility rate with age. So this is the effective age. Annual fertility per 100 women, pretty high at the age of 20, where you guys are at, 2024, with gradual decline because of loss of egg reserve. So they're more likely to have delayed in pregnancy, more likely to miscarry, more likely to have aneuploidy, Down syndrome, and so on. Kind of a more dip here by age 30, and then at the age of 39, 40, we see that the slope becomes a lot sharper, and hence why at this first dip by age 36, that's where we're starting to make urgent referrals. So for fertility evaluation, yes, we're going to check number 1, ovulation. So these ovulation test kits are something they can do at home, but remember our confirmation is our mid-luteal progesterone, 28-day cycle at day 21. For the man, basic investigation is going to be, as we mentioned, the semen analysis, assessed against WHO values. If both the ovulation and the semen analysis are fine, our next check to complete our evaluation for an explanation or unexplained infertility would be a tubal evaluation. So how do we do a tubal check? The principles remain the same, that the passage should be open end to end. So we need to put something at this end of the passage here at the cervix and inject some sort of liquid which we can visualize traversing the fallopian tubes and being spilled on the other end. So the most common ways you will hear about or read about would be X-ray. So you have a radio opaque after you put the catheter in, and you take X-ray, that's a hysterosalpingogram. You should see fill and spill on both sides if the tubes are patent, or see where the blockage occurs. This example here with saline and air and an ultrasound is called hysterocontrast sonography. The air is to make bubbles, which is our echogenic. Air is echogenic. So if you do an ultrasound while doing this, you can obviously evaluate the uterine cavity as well with the saline infusion. Sorry, the uterine muscle, the ovaries. Saline infusion should allow you to see a nice smooth endometrial cavity if it's smooth, or see fibroids or polyps similar to the HSG. See fillage and spillage, right? The third way, which is kind of the gold standard, where you've either failed or you have another reason to do surgery. For example, you suspect adhesions that can be released, like a previous PID or endometriosis case or something. The gold standard test is laparoscopy, which we know about with dye. So laparoscopy and dye, called lap and dye colloquially. The dye is blue. So blue should contrast sharply with any anatomy, which is mostly pinks and yellows in the abdomen. You should see as you inject, so they maybe use a Spackman cannula to cannulate the cervix, they inject the blue dye, and you should see a color tinge here with fill, and then spillage. Blue would indicate spill from either side. You can hold up the tube to see that. But certainly, if you, even though you see the fill and spill and you see dye in the pouch of Douglas, you know that at least one tube is patent. You've done your job. All right. So disadvantage of this is that unlike the HSG and the HICOSI, hysterocontrastsonography, HICOSI, that we mentioned, is that you can't evaluate the endometrial cavity with lap and dye. You'd have to also use a camera through the cervix called hysteroscopy to evaluate the endometrium if you need. Okay, so we have HSG, HICOSI or hysterocontrastsonography, and lap and dye as options for tubal patency. Just to remember, we can only check tubal patency as an openness. There's no way at present to check tubal function, which is, tubes have function with capacitation, preparing sperm for fertilizing. There's some ciliary action to help to waft the eggs and so on. We can't test function, only patency at the moment. So once we have done our test of ovulation, we can determine how to move their progesterone. We can do all the other LH and FSH checks to see, classify, maybe check for PCOS, advise weight loss. Again, they might need treatment with ovulation induction. So the class 2s, ovulation induction, should be things like clomiphene. The gold standard now is letrozole. It's the new standard for PCOS. If we've got a class 1 where they have hypothalamic dysfunction, we mentioned you can give them gonadotropins. This is injections. Alright. Though you might need also to give them, in absence of an LH surge or a trigger, HCG in order to mimic human chorionic gonadotropin, which acts like LH, in order to make them eventually ovulate. So ovulation should be confirmed by, as we said, progesterone greater than 30 nanomoles. We talked about FSH and LH being part of the basal day 1 to 5 evaluation, and above 10 would usually be suggestive of poor ovarian reserve, although isolated raised LH could be PCOS with a normal FSH. All right. And we talked about the poor ovarian reserve not going to have ovulation induction, they need egg donation. All right. If a testosterone level is above 2.5 nanomoles per liter, if you do a basal testosterone as well, that could be implicated in polycystic ovary syndrome. Prolactin level in patients that you suspect from galactorrhea or so on, if they have very high levels, you have to consider that might be coming from pituitary with a micro or macroadenoma, so you might need to do an MRI. Alright, and then they tend to need a dopamine agonist for them to return to ovulation to counteract this prolactin, So something like bromocriptine or cabergoline will help to relieve ovulation problems from prolactin. Hysterosalpingogram or HICOSI, if there's tubal blockage, then in the past they might have done tubal surgery. Nowadays, tubal factor infertility will most often need to have in vitro fertilization to remedy. If there's a hydrosalpinx, remember hydrosalpinges solidify tubal blockage, but they contain fluid. Those need to be removed before IVF because the fluid can reflux into the uterus, and that causes the environment to be hostile for embryos. All right. So remember the gold standard for HSG if it is inconclusive for tubal patency is lap and die, blocked tubes, tubal factor. Tubal surgery could be considered, but IVF more often. Endometriosis, you can sometimes, when you see the endometriosis, treat it at the same time. So diathermy it to burn it and destroy it, excise it, right? Remember that medical treatments are usually contraceptive, or all contraceptive rather. So medical suppression does not help fertility. Sometimes the severe ones that have tubal distortion might need IVF as well. Rubella immunity screening is often done in people trying to get pregnant, as well as persons in early pregnancy. Remember that rubella vaccination is not allowed in pregnancy because it's a live vaccine, so it's a good time to capture them pre-pregnancy in a fertility clinic. So this is a summary of the interpretation of some of the results you'll find and the management. So the male factor of the semen analysis is abnormal. You do that repeat after 3 months usually. And remember, some of the abnormalities can be oligospermia, which is low, is astenospermia, which is poor motility, azoospermia, right? Suffice to say, if you've got oligo, asteno, teratospermia, remember it can be either pretesticular, like a FSH, a hypothalamic pituitary problem, so you would need to check FSH and testosterone, similar to how in the lady you do check FSH and estrogen to rule out menopause, right? Remember azoospermia, very profound allospermia, can check cystic fibrosis because of absence of vas, for which will indicate a blockage, right? In the cases of blockage, the FSH and the testosterone levels should be normal because it's not a hormonal or it's not a testicular problem. So FSH and testosterone, if those are normal, think that there's an obstruction causing the sperm to not get out rather than a problem of production. And similar to the woman, if the FSH is high, right, that can suggest that there's testicular failure, so spermatogenesis failure, complete testicular failure here. So testosterone being normal is because the Leydig cells are still functioning. Leydig cells just produce testosterone, testosterone, not the sperm. If the sperm progenitor is not working, raise FSH, spermatogenesis failure. If testosterone is also low, then it's complete testicular failure. So we're probably looking at sperm donation here, right? So you won't be able to retrieve sperm. You can retrieve sperm from the testicle or the epididymis, like we mentioned in obstructed, and use those for in vitro cycles. If both FSH and testosterone are low, we have to think that's a pretesticular cause, just like in the woman, hypogonadotropic hypogonadism. All right. In which case, sometimes gonadotropins can resume sperm production. So lastly, we're going to introduce you to in vitro fertilization, and we're going to do this at a medical student / GP level. So what in vitro fertilization is basically is in vitro means in glass. Fertilization is sperm and egg coming together to create embryos, just like we saw in previous slides. So we're doing it basically in the lab. So this IVF cycles, so we do look at, just like in menstrual cycles, we look at IVF in cycles, begins basally just like our menstrual cycle. And remember, at the baseline, we expect follicles to be antral. So we don't expect to see any dominant follicles, any cysts or anything like that, right? So we expect that baseline there to be antral follicles. Estrogen levels should be low. All right. So we're going to need two things. We're going to need to stop her from ovulating prematurely, and we're going to need to be able to not just stimulate one follicle like we would in the natural cycle. We need to get all of these follicles, as many eggs as we can get in one cycle. So we need to get all of these antral follicles recruited. So what we need to do is turn off our pituitary control, and we need to grow the follicles. So how we do that? We give her some injections to give herself. So the control of the pituitary is going to be with a gonadotropin releasing analog. And in most cases nowadays, to reduce the risk of ovarian hyperstimulation syndrome, it's going to be a gonadotropin releasing antagonist, such as cetrorelix. So that is going to keep the pituitary from responding like it usually would and recruiting a single follicle and ovulating. So pituitary control, to get our follicles supersized, we're going to need FSH, of course, but not the pituitary FSH. We're going to give FSH injections. So exogenous FSH, this can come from various sources. Human menopausal gonadotropins, for example, the same type that we can use in class 1 ovulation disorders. Recombinant FSH, which comes from genetics in the lab and recombinant DNA technology, or synthetic produced FSH. All right. So we're giving GnRH analog, we're giving FSH, and from our antral follicles, eventually, before we go for an egg collection, we're going to have a situation where we have lots of follicles, hopefully, or at least a good few follicles above 18 to 20 millimeters diameter with eggs in them, hopefully, to try to retrieve as many eggs as we can get so we can fertilize a few eggs. The eggs will need to have a trigger, just like we have a LH surge in the natural cycle. They do need a trigger so that you can collect them, and so they'll be ready to fertilize. So our trigger, which is given 36 hours before collecting eggs, is not LH but HCG, like we mentioned usually. Human chorionic gonadotropin mimics the LH surge in the IVF cycle. Alternatively, if we have used an antagonist, we could use an agonist, but good to remember we use HCG. And remember that HCG can be withheld if you think this lady has a risk of ovarian hyperstimulation syndrome, which is basically ovarian hyperstimulation syndrome is a syndrome where ovaries with lots and lots of follicles retrieve lots of eggs, cause the hormones reduce, cause vasoactive substances and instability of blood vessels, so that you have leakage, ascites, very big ovaries, maybe pleural effusions, and OHSS can be mild, moderate, or severe, or critical, and very bad cases can need ICU care for all those reasons we mentioned, extravasation of fluid, albumin, respiratory support. So we want to avoid OHSS as much as possible by careful stimulation and careful maybe withholding of HCG if necessary. All right. That's just the last slide because I know OHSS sometimes comes on your MCQs. So pituitary control, FSH, supersize the follicles. HCG trigger 36 hours before egg collection. Egg collection, we can see here a needle. It's transvaginal ultrasound guided. The ultrasound probe is in the vagina, and connected to it is a guide. You can pass the egg collection needle along that guide into each follicle in turn, just manipulating the probe. They usually will have some sedation and painkillers, sometimes general anesthetic for the procedure. It's quite relatively simple and relatively straightforward, and very few complications. Mostly, sometimes a little bit of bleeding, which is easy to control. So manipulation of the probe will allow you to go from follicle to follicle to follicle and aspirating them so they're empty, with the eggs being contained in that. So then the eggs being collected in this way is by vacuum, or be collected in test tubes, which are again kept at body temperature and handed off to embryologists who deal with the gametes and the embryos. So here's to show the ultrasound guided egg collection, like we see here. Ultrasound probe in the vagina, aspiration of follicles. The follicle fluid goes to the embryologist, and they have their microscope ready. They can find the eggs in there. Of course, the partner is going to give his semen so that the embryologist has access to both the sperm and the eggs. So that is produced just like the semen analysis manually after maybe 2 days or so of abstinence to have the best quality sample. So we had that stimulation, we got eggs, we retrieved them in the lab. This is in vitro fertilization alone. We have them incubated body temperature, maybe it's an incubators or embryoscopes. Eggs and sperm together, provided that the sperm sample provided by the man was normal with normal motility and so on. The sperm and eggs should find each other, combine, fertilize, and you have embryos. So between 3 days, you get cleavage stage embryos, but day 5 or so, 6, you get blastocysts. And remember, we said that blastocysts are the ones that tend to implant in natural cycle. So once we've got those eggs fertilized, so we check them to see that they fertilize, we check to see how they've grown. We hopefully can culture some to blastocysts. We can, once they're ready, and of course the lady will have to have some progesterone support of her endometrium, just like if she's kind of pregnant. That is done through some progesterone tablets in the vagina usually. So she would have been taking her progesterone after her egg collection vaginally. Embryos are ready. She's brought in to the clinic. They put an embryo catheter through with the embryos loaded. Usually 1 embryo, maybe 2 sometimes, depending on how things have gone, and inject the embryo into the uterus under ultrasound guidance. Remove the catheter. All the things done gently. And then 2 weeks later, after her 2-week wait, 2WW on the forums, she can check to see if it's all worked. Any extra embryos that we got from all those eggs and sperm that look brilliant can be frozen for future use, so that we can cut out all of the egg collection cycle a bit and so on, and just do preparation of the endometrium, usually with estrogen and the same progesterone inserts, and just thaw embryos that were frozen and transplant the same way. So that is IVF in a nutshell, quite simply. And this is just to show that the advanced technique of intracytoplasmic sperm injection, or ICSI, ICSI, intracytoplasmic, because we're going directly into, this is the oocyte, and here we've got the corona. So we've got sperm drawn up into a pipette, stabilizing catheter here, and we have the sperm which has been mobilized, injected directly into the cytoplasm of the egg, hence intracytoplasmic sperm injection. So this is used if you have only very few sperm, like in an oligospermia situation, you want to ensure fertilization. If you have surgically retrieved sperm, maybe HIV affected sperm, maybe if they've had IVF in the past and the eggs didn't fertilize, ICSI is a good way to go. It is of course more time consuming and more technically challenging, and hence more costly, hence why therefore it tends not to be routine, although there might be drives in the future to do that, to change to that. Who knows, it's all still up for debate. So that is IVF, and this is ICSI. So to wrap up the tutorial, infertility is a common problem and affects couples, 1 in 7 problem. Thus we must see partners together and evaluate them in tandem. Good history taking is important, and it might reveal lots of useful clues and might very well make a diagnosis for you. So in our evaluation, we're asking a few key questions. Are there eggs? So ovarian reserve, and the key ways to check ovarian reserve, we mentioned the basal FSH. We should also mention anti-Müllerian hormone is a good way to check ovarian reserve, because it is produced by granulosa cells, so it isn't cycle dependent, and it tends to be leaning towards the gold standard way to assess ovarian reserve. And then we can also look at antral follicle count. So 3 ways: FSH, AMH as the gold standard, and antral follicle counts. So are they eggs? Are they being released? So is she ovulating? That's your mid-luteal progesterone. Are they sperm? So that is, your semen analysis. And if they are eggs, they are being released, and they are sperm, are they meeting? So are the tubes blocked? Start your evaluation at the appropriate time, early. If you're over 36 in your late female partner, because remember it gets urgent at that point, or if pathology is suspected. Otherwise, you do wait for that. Usually wait for that year, in which time 85% of couples would have conceived. Folic acid. Remember, 400 micrograms when trying and up to 12 weeks of pregnancy, except for those scenarios where you need 5 milligrams. And remember, you always say sex every 2 to 3 days. Then they might not even need anything more than that. So that ends my talk. I thank you very much for your time, and have a great day.